who is a nurse in a primary healthcare practice in Norway, to come and share with us the first-hand experience of what it is like to be working at primary healthcare level in 2023. Abiel, a warm welcome to you. Thank you for having traveled so far. Please stand on my right and left and please share with us your thoughts this morning.
Thank you so much. I'm very nervous speaking to you all, but I'm very excited to be here. And I feel like I have an important message for you all. I've been a nurse for 25 years, and I've worked primarily with the elderly in primary health care. I've worked in home health many, many years, and in nursing homes. What I've seen changes during the last 25 years that are difficult to manage. One of the main challenges is the complexity of our patients. They're coming home from hospitals with much more comorbidities, and they're challenging to meet. And while before they were mainly staying in hospitals in a rich professional environment, now they're coming back to the communities, and we're expected to know or to figure out how to deal with it, and not necessarily getting the training that we need to meet them. Alongside this, society is moving very, very fast, and we're always expected to do more with less. And one of the issues that, where I come from in Norway, one of the things that they've done to try to be more efficient is to take away support staff. And this means that healthcare workers have to do more things that aren't necessarily healthcare related. Because in Norway we have an expression that nurses are like potatoes. Potatoes can be used in many dishes, and so can healthcare workers. They can do mainly anything. So in Norway we use healthcare workers to clean beds, dust the patient rooms, empty trash, cook, and serve food, as well as doing procedures like putting in IVs or giving shots. We're running so fast to get through all our tasks that we're forgetting some of the core values. The value of caring for our patients. Healthcare workers who previously felt like they could make a change for their patients are in the process of giving up hope. I see a rise in coworker apathy, and it worries me. I see that we're getting these demands, and we're being bombarded with the principle of delivering care at the level of just being good enough. It has to be good enough, but not too good. Who is the one that decides what's good enough? Who is the one who decides the quality of care? Is it the economists that are talking about the money aspect, or is it the patients? And I would argue that we're here for the patients. So I think they should be the ones that are telling us about the quality of care and what's good enough. Do you know that there are some people working in healthcare that are so stressed that they don't even have time to smile to their patients? I think that many of you, if you were a patient, you would want the people taking care of you to see you. I think you would want them to have the time to smile and to have a conversation with you. I need to tell you that I'm worried about the future of primary health care, and I'm worried about my role in it, because I worry about having to constantly decrease the quality of care just to get through the day. I think that policymakers are generally very far away from the patients and far away from real life. I think that you might have grand ideas. You might have these ideas of making things more efficient, but you don't know what's going on down there on the floor, as we say in Norway. You don't know that a patient is lying in a hallway, maybe somewhere, because they don't have enough patient beds, and nurses are running around and not having time for them. You don't know that there are lonely people in their houses without people being able to come and talk to them, because they have to run in, give their medication, and go out again, just to get the basic needs done. I think that we need to value conversation as a medical aspect of care. I think that we need to use our time to talk to patients and see that this is a valuable intervention. It's just as important as putting in catheters or giving out medication. Conversation with our patients, relationships with our patients is important. How else do we figure out what they need if we don't talk to them, if we don't take the time? So I want to share with you a dream that I have for policymakers. My dream is that you will value the creation of connection with patients, that you'll value the time that we need to build relationships with them, because this is what helps us identify their needs and do something about them. And as to the increasing complexity of the patients, I think that policymakers need to improve access to further training. We need continuous training, and it has to happen at our workplace. Stakeholders need to invest in training. And I also hope for a speedier integration of digitalization that will benefit not only our patients in being able to do things for themselves, but it'll also give us time to get back the time that we lost with our patients. And I hope that policymakers will recognize the need to invest in primary health care. Because I've seen far too often that community health care is not prioritized. And I say, enough is enough, because who are we here for? We're here for the patients. So we need to focus on the patient's needs first of all.
Thank you very much, Abiel. Your insight and heartfelt reflections are greatly appreciated. Colleagues, I think this testimony really brings to life what primary health care is all about. Primary health care is about caring for our people. It is about ensuring that everyone is taken care of, that health services reach the ones that are most in need. And the people who work in primary health care are our most precious resource. So let's clap once more to acknowledge Abiel and all the health workers she represents. Thank you.
Yes, and sorry for that little intermezzo between us. We understood that our patient has arrived who would also like to give us a testimony. Thank you very much, Kopey Davletbayeva, for being with us. And please come out, join us here to tell us a little bit about yourself and your experience as a patient to seek services at the primary healthcare level. Thank you very much for being here, for being with us today.
Сәлеметсіздер ме? Астана қаласының қонақтары. Сәлеметсіздер ме? Астана қаласының қонақтары. Мен Davletbayeva Kopey 9-шы емханада тіркелгенмін. Біз жанұямызбен отбасылық дәрігерге қаралып тұрамыз. Мен көп жылдан бері гипертензиялық давлениемен және созылмалы бронхит ауруымен есепте тұрғандықтан 3 ай сайын дәрігеріме барып көрініп, керекті дәрі-дәрмегімді тегін алып тұрамын. Ал егер де бара алмаған жағдайда емханаға маған дәрігерлерім дәрілерді үйге де жеткізіп береді. Бұл әрине жақсы, әсіресе пандемия кезінде ыңғайлы болды. Тағы да айта кетерлік жағдай, мен денсаулық мектебіне және ауруды басқару бағдарламасы кабинетіне барып тұрамын. Ол жерде салауатты өмір сүру салты, аурудың алдын алу қалай керек, қалай тамақтану керек, өз-өзіңді бақылау туралы бізге толық түсіндіріп береді. Сондықтан да менің денсаулығым жақсарды. Біздің отбасымызды жылда уақытында скринингке шақырып тұрады. Менің немерелерім де туылғаннан бері отбасылық балалар дәрігеріне қаралып тұрады. Вакцинация және профилактикаға барып тұрады. Ол жерде баланың даму кабинеті де бар. Онда бала дәрігерлері отбасылық мейірбикелер жұмыс істейді. Қойылған сұрақтарға толық жауап беріп, бала қалай тамақтану керек анасымен, қалай дамиды, соның бәрін айтып түсіндіріп береді. Оларды балалар жақсы көреді. Ол жерде ойыншықтардың көптігі сондай, балалар олармен ойнап отырғанда өздерін қалай тексеріп, қалай тыңдағанын білмейде қалады. Әрине, біздің Қазақстанымызда медицина дамуда, жаңа дәрі-дәрмектер, жаңа емдеу әдістері пайда болды. Бұл жерде отбасылық дәрігердің түсініктемесі біз үшін өте маңызды. Бүкіл медицина қызметкерлеріне, дәрігерлеріме, мейірбикелерге, кәсібилігі, мейірімділігі, назары мен қамқорлығы үшін рахмет. Алда келе жатқан республика күні құтты болсын. Елімізде тыныштық, бейбітшілік болсын. Сіздерге жақсы денсаулық, отбасыларыңызға аманшылық, жұмыстарыңызға сәттілік тілеймін. Тыңдағандарыңыз үшін рахмет.
Көп рахмет, dear Kopey, Davletbayeva. I wish all patients in the world had access to such services and care as you described.
Colleagues, before moving on with more insight on primary health care and our experts, let's remind ourselves of how our understanding of primary care came to be by watching a short video prepared by our colleagues in the WHO Eastern Mediterranean region.
Many countries have failed to uphold the basic human right of everyone to optimal health without discrimination. This right continues to be a distant dream for too many. The 2018 Astana Declaration reaffirmed the commitment of countries to strengthen primary health care as an essential step towards achieving universal health coverage and health-related sustainable development goals. The World Health Organization's operational primary healthcare framework aims to support countries to scale up efforts that ensure that all people, everywhere, have access to high-quality, equitable, and affordable primary care. This framework encompassed 14 levers that defined everything. Appropriate models of care include high-quality, people-centered primary care as the core of integrated health services. A successful model delivers sweeping changes throughout that ensures the right care is delivered at the right time, by the right team, in the right place. Recognizing that strengthening primary health care through the establishment of country-specific models of care is essential to achieving universal health coverage. For instance, the Regional Professional Diploma in Family Medicine is giving general practitioners the knowledge, skills, and attitudes they need to deliver a comprehensive package of essential, high-quality, effective healthcare services, while ensuring patient safety and quality of care. Creating a sound partnership between public and private sectors, and harnessing evidence from the lessons of the pandemic has meant we are better able to respond to future health emergencies. We have come a long way. We have seen positive changes, but we need to do much more, building resilient health systems based on primary health care and sustain progress towards universal health coverage and health security, leaving no one behind.
Leaving no one behind. It is now my great pleasure to introduce Dr. Natasha Azzopardi Muscat, Director of the Division of Country Health Policies and Systems at the WHO Regional Office for Europe, who will deliver the keynote presentation of this session. Dear Natasha, welcome.
Thank you very much, Gabriele and Melitta. Good morning to you all, and what an opening it's been. It's been so rich. We've heard from politicians, we've heard from our WHO leaders, but we've also heard from experts, professionals, and patients. And I think that we have a very clear picture painted already before us to guide us through the day. We know that there is hope, there is optimism, there are things happening, but we are also aware of the challenges that lie ahead. And in the next 15 minutes or so, I have been asked to reflect on what is happening in primary healthcare over the last 5 years since we have convened in Astana. And I believe that some of these key messages have already emerged. But let's highlight them. Can I have the next slide, please? Because the clicker is not working. It's working now? That is the QR code for people who would like the translated presentation. Here we are. So, Declaration of Astana. In a nutshell, what was new? What was different? We really had a bold political commitment to reorient our health systems to primary care and to really build upon health across all sectors. And there was also the commitment to build sustainable primary health care. But what has happened in these long 5 years? For many of us in the room, the COVID pandemic, of course, has been something that we've had to deal and grapple with. But for others, perhaps it's been the impact of conflict or of fiscal constraints and economic insecurity. And all of this might lead us to think that not much has happened. But that is just a selection of the key milestones that we have achieved together. WHO working at the 3 levels of the organization, together with member states and civil society, with young people, with representatives, with parliaments. And I just highlight a couple over there. The resolution that was adopted by the World Health Assembly, followed by the operational framework. But also I've put on the screen that in WHO Euro, we had a resolution on primary healthcare at the height of the pandemic in 2021. And I know that colleagues from other regions of WHO have similarly taken the opportunity to operationalize the Astana Declaration in practice. And of course, more recently, we have come from the UN high-level meeting on UHC. So I believe we can truly say that in spite of everything that may have derailed us, we can confirm and affirm that there has been a steadfast commitment to advance the agenda that we signed up to in Astana. But let us remind ourselves that at the end of the day, primary healthcare is a means to an end, because what we are striving to achieve, going back to the roots of the Almaty Declaration, is health for all. So if we just for a moment take a step back and look at the bigger picture, where are we? And we know, for example, that primary healthcare, when effectively executed and delivered, and when it reaches those who are truly in need, can make a huge impact, for example, in a very cost-effective manner on reducing premature mortality from non-communicable diseases, cardiovascular diseases, cancer. We know that many countries, for example, are now piloting and rolling out screening programs for cancer. But we also know that there is effective primary and secondary prevention for cardiovascular disease, for stroke, that can be delivered in primary healthcare. So where are we? As you can see, premature mortality in all regions of the world has declined, but you will also see that there is a gap between where we want to be in 2030 and where we are. And that gap, far too often, is concentrated in those with lower education, with lower means, or also in certain parts of the world. Another area that has been mentioned by previous speakers, including UNICEF, is the area of maternal and child health. Of course, synonymous with quality primary healthcare delivery. And again, we can see, on a positive note, that we have made progress, but it is, as yet, unfinished business. And when we still have 5 million deaths annually, that is a gap that remains for us to close. Another indicator that we often use to see how primary healthcare is progressing is avoidable hospital admissions for chronic obstructive lung disease or asthma. In those health systems where primary healthcare delivers and delivers well, we can avoid hospital admissions. This has good results for the patients, but also is economically effective. And we see that over the past decade, in many countries, progress is being made. But again, when we look at the Service Coverage Index, and we heard also earlier this morning how, for example, Kazakhstan has made remarkable gains in terms of its Service Coverage Index, but these gains have been uneven, and there are still many countries across the world where we have to do better. And this was the key message of the report on universal health coverage issued in September. So, what is happening across the region, and where is the trajectory of travel? And I would like to talk about 4 key areas that we observe. The first one being that primary healthcare has moved from a one-size-fits-all, what was initially 40 years ago the goal, the image. It's now become very diverse because it has to tailor to the need of the communities it is serving. The second point is that there's been this shift, this massive shift from monoprofile teams to multidisciplinary teams. But again, not yet everywhere. It's work in progress. The third area, that we are taking primary healthcare from the waiting room to homes and communities. And finally, that primary healthcare is evolving from having the clinical skills and expertise that are so necessary, but also embracing wider non-clinical skills too. So let's unpack these in a little bit more detail. And on the slide over there, what I try to capture is that there is no single image of what primary healthcare should look like. Maybe in years gone by, we had photos of a doctor, typically a man, 50 years ago, 70 years ago in many countries, that was still the reality, sitting in a room with a stethoscope around his neck and a sphygmomanometer. But that is no longer the image of primary healthcare. Primary healthcare is delivered in people's homes. Primary healthcare is delivered in rural settings by different professionals. But primary healthcare is also becoming increasingly complex. And we are seeing that primary healthcare, for example, in urban areas and wherever there are larger population settlements, is also delivered in a complex manner and requires access to technology and to therapeutics, because a professional on his or her own, without this access to the technologies and to the the equipment that is needed is not in a position nowadays to deliver the quality primary healthcare that people legitimately expect. Moving on to unpack the second point, the future of primary healthcare is multidisciplinary, of course, and we saw this very clearly during the COVID pandemic. But, and here I must pause, as we look across, for example, the European region, we published our report on the status of the health and care workforce. We find that many countries are actually struggling to recruit and retain healthcare workers in rural areas in primary healthcare. So if we really want to continue to ensure that primary healthcare remains the bedrock, the anchor of our health system, again, we must do more to ensure that we have the full breadth of disciplines that we need: doctors, nurses, midwives, pharmacists, allied health professionals, psychologists, social workers, data scientists, public health professionals. This is what we mean when we talk about multidisciplinary teams, because this is the broad skill set that is needed. But for primary healthcare to continue to grow and thrive, we have to find ways to attract young people to primary healthcare, and we must find ways to attract the best people to primary healthcare. Because primary healthcare is not simple. Primary healthcare is actually complex. Primary healthcare requires that one carries responsibility, that often you need the most senior people there, delivering outside, far away from a hospital, taking the best decisions. So let us put to bed the myth once and for all that primary healthcare is simple care. No, primary healthcare is actually complex, it's demanding, it requires us to have the best people out there. We heard several times already this morning about digitalization. And clearly, primary healthcare is one of the areas of the health system that really stands to benefit from digitalization. Again, digitalization allows primary healthcare to enter people's homes, people's workplaces, to have consultations that really revolve around the needs of people. We heard also about remote monitoring, for example, physical parameters. But it's also the possibility for primary healthcare networks, particularly between urban and rural areas, for example, to be able to connect, to communicate. And even more importantly, it allows primary healthcare to be able to bring the hospital specialists out to patients through the intermediary who is the primary healthcare professional. And we are seeing examples of all of this happening, and it's exciting times. We heard also about the importance of regulation of AI and digital, and we need to do so, but let's make sure that we do not stay in the comfort zone of just digitalizing hospitals, but we actually move out to digitalize primary healthcare. And for this to be successful, of course, we need to work far better on digital health literacy of our populations, particularly of older persons, of people who live in rural areas, who can stand to benefit greatly from this innovation, but who paradoxically are often the ones who are being left behind in the midst of all this innovation. But again, all the technology in the world cannot substitute that smile, that human touch that our primary health professionals give to people. And when I was hearing Abiel from Norway saying, we are no longer having time to smile, we are no longer having time to care, that is a very serious wake-up call, because that demotivates people who entered the profession to care and to serve. it gives rise to a term that is being increasingly used, moral injury. In other words, the gap that professionals feel between what they signed up to deliver and between what they are able to deliver. And also, of course, this is really what people need, because at the end of the day, primary healthcare works with people. So there is no way we can substitute the humanity and compassion of primary healthcare. And let us be mindful that in our rush to embrace digital solutions, we do not forget this really important element. Which brings me nicely to addressing the topic of mental health in primary healthcare. We seem to have rediscovered this during the COVID pandemic somehow. Why? Because in many countries, unfortunately, we see rising epidemiological trends of anxiety, of depression, particularly in children and adolescents. But let's pause for a moment. Let's take ourselves back to the time when the World Health Organization was being set up. And those founding individuals in their wisdom coined the definition of health as a complete state of physical, mental, and social well-being. So it's really been there throughout. And when we talk about delivering the primary healthcare approach, of course, it's not only the physical health, but also the mental and the social well-being. And many countries are now, because they are facing such huge demands, we hear, for example, of countries where 1 out of 2, 1 out of 3 consultations in primary healthcare have an associated mental health component. We have to find ways to bring the right model of care. And again, the solution is primary healthcare linked to specialist services where necessary, so that one can care, can treat what is treatable in a community setting, but can have early diagnosis and referral to specialist services where this is needed. But I'd like you to focus on the 2 bottom quadrants, because this is something we haven't spoken about much. Legislation and governance. If we really want to shift the center of gravity of our health systems from hospitals to primary healthcare, we must, of course, have the legislation and the governance systems in place. Because in some countries, for example, people working in primary healthcare, doctors and nurses, cannot work in the area of mental health because the legislation is not in place to facilitate that. And some time ago, I think it was when we were doing our warm-ups in the last 4th virtual roundtable, I was asked pragmatically, how are we going to make this shift happen? And I said, well, I remember when I was working as a policymaker in my home country, Malta, I probably made 50 to 100 decisions a day, sitting in the Ministry of Health. Let's just stop with every decision that implies some governance element and ask ourselves, are we strengthening primary healthcare, or are we actually disempowering primary healthcare through the decisions that we are taking? And the 4th quadrant, partnership. Sometimes in the health sector, we think that we can do it all. We can't do it all. We have to work with others. And for example, when it comes to mental health, in the European region, we have set up the Pan-European Mental Health Coalition because we realize that it's everybody's business. Primary healthcare also, talking about people with mental health problems, needs to be able to proactively reach out to people at high risk and the vulnerable. And they can be at high risk because they have cardiovascular risk factors or a family history of cancer. Those are people who are at high risk of certain illnesses. But there are other people who are at high risk, for example, because maybe they have just lost their job. What can we do? We can use the power of big data, of AI, of analytics, to give us that information at our fingertips, to have heat maps, to know immediately where the problems are. And of course, this matches the human primary healthcare experience. Because people like myself and yourselves who are attuned to primary healthcare know that you don't actually need the epidemiological surveillance reports to know where the problem, where the hotspot is, where there is an issue that needs to be tackled, because you know, because you are part of that community and you listen. But of course, this is again where the human touch needs to remain. AI and big data can tell you where the problem is, but it's going to require human endeavor to reach out to those who are vulnerable and at risk of falling behind, because they will not come. And if you're interested in learning more about this, we've just issued a policy brief on population health management, where we bring together primary healthcare and public health. And well done to our colleagues in Almaty for pulling this one together. So, I realize now that our regional director and Madam Minister are back with us, so I can come to conclude my presentation, and we will have the first plenary with a few key messages. We know that higher public spending on primary healthcare is associated with better service coverage. At the moment, we see that many health systems, solidarity is being threatened. Public health services cannot cope. As a result, we are seeing a shift of certain parts of the population to the private sector, where often they are paying out of pocket, with the consequences at hand. And in December, we will launch data from across 40 countries in the European region on financial protection through our Barcelona office. So I need to make the case over here that we need to safeguard public spending on our primary healthcare systems if we want to live up to the notion of health for all. Secondly, we spoke about the workforce, we spoke about the primary health workforce. We have data for GPs as a tracer. It's not enough, but let's start with that. And what do we see? That in some countries, GP workforce density is increasing. But in the European region, in 17 countries, it has decreased in the last years. And in primary healthcare, in many countries, we have an aging workforce. So we've called this a ticking time bomb. But let me just draw your attention to something else. As in many countries, the healthcare workforce density is increasing. In other words, the number of health professionals available in a country increases. Just keep your eyes on that ratio between primary healthcare and hospital services. Because looking more closely, it's one thing to look at the overall numbers increasing, but when you look closely at that ratio, in many countries, what we are beginning to see is that actually that ratio is worsening, and that when we talk about having more health workers, they are not necessarily in primary healthcare, and therefore we cannot shift the health system towards primary healthcare unless we have the workforce. And another take-home message: we cannot deliver in primary healthcare if we do not provide access to medicines in the outpatient settings, particularly for those who need them most and who are least able to afford them. And this is another blind spot of many health systems, where we provide the consultation with the professional and we don't follow up with the medicines. And I was delighted to hear yesterday that in Kazakhstan, the list of available medicines covered free of charge has increased and now stands at 126. So I see that Melitta is hovering, and I will just come to my last take-home messages here. Establish and sustain primary healthcare teams. We need to think of all the team. Thinking of one professional in isolation is not enough. Secondly, if we want these teams to be able to deliver, let us equip them with the technology, with the medicines, with the diagnostics, and let us empower them by having the right legislation and governance in place. By all means, let us ensure that our digital solutions are in primary healthcare, but it takes two to tango, so the patient population must also be able to use digital solutions with confidence. And finally, let us continue to advocate to ensure that as times get tough and as fiscal constraints increase, primary healthcare is not the first casualty, but that we preserve and increase the funding on primary healthcare even in tough financial times. Thank you very much.
Thank you so much, Natasha. You are comprehensive in articulating the dimensions, opportunities, and requirements for a strong primary health care. And you gave an extremely insightful presentation with clear messages that set the stage for our experts panel.
And now we come to our first panel discussion, and I have the honor to invite our panelists to join us here. Madam Minister Azhar Giniyat, Minister of Health of Kazakhstan, please join us. Dr. Tamar Gabunia, First Deputy Minister of Health, Georgia. Zulema Altamirano, Deputy Director, Ministry of Health, Spain. Sura Wisedak, Director General, Ministry of Health, Thailand. Dr. Hans Kluge, our Regional Director for WHO Europe. Bruce Elward, Assistant Director General for Universal Health Coverage, WHO. Octavia Ambival, Deputy Regional Director of UNICEF, and Bernd Appelt, Senior Official of International Aid in the European Commission. Welcome. Thank you very much. Please take your seats. Some of you are probably seated a little bit further in this big conference room, and takes us a little bit longer to get together. And let us start with our host country. And Madam Minister Giniyat, let me thank you for hosting us all here. Yesterday you have recounted, and your colleagues have recounted, of the success of Kazakhstan in transforming primary healthcare. We have two amazing posters in the foyer that also tell the story. We have recently launched a case study. But what's really interesting us in this panel is clearly political support is a key ingredient of success. And we have seen national level leadership with Mr. President being here, with yourself, with your team being here. But how about the significance of regional leadership, local leadership? How are you able to boost that in your large country like Kazakhstan? The floor is yours, Madam Minister.
Благодарю вас за вопрос, госпожа модератор. Казахстан придерживается политики укрепления и сохранения здоровья людей и совершенствования оказания ПМСП. У нас нету, скажем, другого выхода, так как ПМСП, Алматинская декларация, это вот ассоциируется с Казахстаном. На сегодняшний день катализаторами преобразования, укрепления ПМСП в нашей стране являются несколько ключевых факторов. В первую очередь, как вы уже заметили, я думаю, это политическая, очень высокая поддержка руководства страны, и все стратегические документы в системе здравоохранения начинается с основного направления, это направление совершенствования первичной медико-санитарной помощи. Сегодня хочу сказать, что, понимая, что обеспечить доступ ПМСП каждого нашего казахстанца необходимо не только финансирование, но и надо улучшать инфраструктуру, большие инвестиции, и в этом направлении Казахстан работает. В первую очередь, это, конечно же, финансирование. Если ВОЗ нам рекомендует, что от общего расходы на здравоохранение, финансирование ПМСП должно быть 60%, так как оказывается там больше услуг, должны мы оказывать там больше услуг, то на сегодняшний день Казахстан достиг уровня 56%. И каждым годом поставлена у нас цель улучшить финансирование, этим внедрять новые технологии, обеспечить доступность услуг, разнообразить услуги, чтобы население мог возле своего дома, аула, в городе получать медицинские услуги. Второе – это инвестиции в здравоохранение. На сегодняшний день, понимая, что необходимо обеспечить полный охват, мы привлекаем частную медицину. 47% медицинских организаций, которые оказывают ПМСП, это частные организации в Казахстане. Также реализуются проекты в рамках ГЧП, государственно-частного партнерства, такие услуги, как диагностические, консультативные услуги, в том числе дорогостоящие услуги, пройти КТ-диагностику, рентген. Сейчас вот развивается и ПЭТ-диагностика, это с участием частных инвесторов. Инвестиции также важны в кадры. Мы это понимаем. На сегодняшний день обучение, в первую очередь, сотрудников, работников ПМСП, также обеспечить их нормальными условиями работы, инструментами для оказания на высоком уровне медицинской помощи. Это вот инвестиций, в этом направлении тоже очень много мер запланировано и реализуется. Третье, основное, мы об этом с гордостью заявляем, что в Казахстане на уровне ПМСП оказывается интегрированная медицинская, социальная, психологическая помощь. Мы интегрировали свою противотуберкулезную службу, психиатрическую службу, онкологическую службу, ПМСП. Сегодня наши граждане его могут получить на амбулаторном уровне. Также хотелось бы отметить следующий фактор, и это очень важный фактор. Мы этим сейчас занимаемся, это развивать партнерство с пациентами и местными сообществами. На сегодняшний день в каждой медицинской организации, которая оказывает первичную медико-санитарную помощь, созданы службы поддержки пациентов. И также очень активно привлекаем сообщество, чтобы вместе решать те проблемы, чтобы больше информировать население о проводимых медицинских услугах, о новшествах, по проведению профилактических мероприятий. Привлекаем такие сообщества, как клубы пожилых пациентов, людей. Это общества, скажем, влиятельных, уважаемых членов общества, которые работают тесно с медицинскими работниками, объясняет, продвигает меры профилактики, а также получение медицинских услуг. Вот основные ключевые факторы, которые, я думаю, дало нам совершенствовать первичную медико-санитарную помощь.
Thank you, Madam Minister. Indeed, the primary healthcare vision from Astana is a formidable undertaking that requires complex solutions and effective leadership. Dear Hans, from your experience as a medical practitioner and a leader in health, what do you think are the critical aspects of leadership that are required for the effective implementation of these transformative changes?
Thank you, and once again, I would like to congratulate Kazakhstan for the National Day, Madam Minister, and congratulations for holding the flag of the primary healthcare. It's as if I was here 5 years ago. So a number of points. I think we all have to recognize, listening to your testimonies, that such a transformation requires blood, sweat and tears. So there is no shortcut. It requires a lot of personal resilience, a lot of high-level commitment, and what I call coalition of the willing. Actually, I compare it a little bit almost with WHO transformation to reform. You need to have a vision. That's very important. To rally all the different parties around the table, including the opposition, so at least they have the opportunity to express their opinion, that they are feeling hurt, but then you need a coalition of the willing to move forward on the implementation. This is number one. Number two, I would say, is, I call it a kind of a flywheel effect. You have to start somewhere. So it's good to start, if I look to experiences, from some quick, visible wins that you can show to the people, to the politicians, that the transformation is working. Number two, then to remove some very concrete obstacles or barriers. Because people in general are very willing, to do what has to be done to improve health of the people, but there are many obstacles in the way. Sometimes it's inertia. And we have to make sure, I always say, it's not my job to motivate my people. If you work with my team, I expect that you're motivated. But it's our job not to demotivate the good willing people. So we need to identify the champions, the people who are enthusiastic, and then incentivize them to do the right thing. And with this, it's like, this flywheel, it's a huge wheel, very, very heavy. And you need to put your shoulder on it in order to get it a little bit of speed. And in the beginning, it's very, very heavy. But once that the flywheel is getting speed, it goes faster and faster and faster until a moment you can no longer stop it. A very important enabler there, in my experience, is what we call distributive leadership. Actually, what Kazakhstan is doing, Madam Minister, it's not, the old-fashioned top-down only. Only we have prikaz и все. No, we need bottom-up also. It means to have like mini World Health Assemblies where we are gathering, especially the healthcare workers. Actually, I like a lot, Melitta, the nurse from Norway, who was telling, and congratulations with this Let's Talk PHC TV shows, which I become addicted. So the Norwegian nurse was telling, the higher you get in the hierarchy, the further you get from the patients, and it's almost, let's say, difficult to avoid that you formulate policies without linking back to the people, to the patients. That's why always if I go to the countries, I always would like to see primary healthcare center, speak to the doctors, the nurses, to the patients. And they are telling us what is working and what is not working, and what to have to improve. So we need to be, as a leader, very good listener. Actually, there's a proverb which says, if you want to go fast, go alone. If you want to go far, go together. And maybe a final point is on the communications. I put a lot of effort also into our own organization in the regional office, into our director team, our managers. we have to be the good communicator. Because very quickly we can talk a language that the people have difficult to understand. We need to use simple language. I always tell to my press communication people, if there is a press release and my granny, my grandmother does not understand, we have to rewrite the press release. We have to tell the people very concrete things that they can do, what we can do, the politicians, and to move forward. Always it needs to be based on evidence. That's very important. On science and evidence. And we saw in COVID-19, it not always happened. If we leave the evidence aside, this is a very slippery slope. Now, is the glass half full or the glass is half empty? I must say, comparing with 5 years ago, Melitta and Gabriele, I think we really succeeded to initiate, Madam Minister, a primary healthcare movement globally. And what is important for me, it is rooted in strong ethical principles and values. If you look what's happening in the world, we are the one to hold the flag. Equity, universality, solidarity, these are no empty words anymore, leaving no vulnerable person behind. So it's rooted our movement in strong ethical values. At the same time, remember what Mr. President told. He wants us to see pragmatic, business-like. So we need to implement successful, tailor-made solutions. Every context needs its own solution. And that's why this primary healthcare movement, driven forward by Kazakhstan, by you, Madam Minister, by President, is so important. Thank you again, everyone, for being with us here today. This means a lot of enthusiasm, and I wish you good health and good conversations. Rahmat.
Yes, thank you, Hans. I really like this image of the flywheel. And just imagine if each 500 of us were standing by this flywheel, I think it would start moving really fast and we could really not stop it. Now let's move to Spain. Spain is a country that boasts some of the best health outcomes at the lowest cost in the world. So we are often studying the Spanish health system, and the Spanish health system has had several decades-long commitment to primary healthcare in the center. What we're talking about now, Spain has been doing for 40 years. I'm very happy to have you on the panel, Zulema Altamirano from the Ministry of Health. And we would like to hear from you what it takes to maintain commitment over such a long period of time, and what would be your advice for other countries. But before I give you the floor, your Secretary of State would have liked to join us, but last minute was held back. She sent us a very short video address, and then I will call on you to make your live presentation.
Experts, ladies and gentlemen, good morning. First of all, I would like to apologize for not being there in person with all of you to share our common commitment on primary health care, but urgent matters are keeping me at the ministry. I would also like to thank you for your kind invitation. The healthcare model implemented in Spain pursues the logic of networks based on PAC with key elements such as continuity, people receiving care at different stages of life, from health teams with an established relationship with them, and geographical accessibility, with a total of 13,000 health centers spread throughout the country, which assist 364 million visits and 29 million emergencies per year. Our PSC model allows for a comprehensive, close and continuous care of individuals, families and communities over time. It reaches the entire population regardless of their socioeconomic level. therefore ensuring health equity. This strong and well-established structure has made it easier for Spain to cope with the impact of the events mentioned earlier. Primary healthcare continues to be highly rated by the public. According to the last month's health barometer, 83% of Spaniards consider PHC attention to be either good or very good. But our model also requires to be adapted to the new needs of the population, mainly due to the increasing of the life expectancy. This new reality involves the response properly to complex health needs. We had to do it by taking advantage of the innovation and new technologies available. And we have to do it together. Because as you know, in Spain, the competence in healthcare are transferred to the autonomous regions, with the Ministry of Health being responsible for their coordination. And I believe my colleague Sulema Altamirano, who is present at the stage, is going to take it from here. Thank you.
Thank you so much. As following the Secretary of State of Health intervention, as it is shown in the case study in primary health care in Spain that is being launched by the WHO European region, today to respond to these needs and also to adapt to new developments in the health sector, in 2019, a strategic framework for primary health care was launched and was defined in Spain. And it was a result of a consensus of central and regional governments, professionals, scientific societies, patients, and citizens. And it includes 6 lines of action aligned with those identified areas of improvement. However, the implementation of this strategic framework was interrupted by the COVID-19 health crisis, which further aggravated some of the primary health care's problems and weaknesses. The new scenario requires strengthening the system to address both health and social crises, and for it, the Ministry of Health, together with the autonomous regions, approved together the Primary Health Care Action Plan 2020-2022-2023. There, primary health care was a subsystem within the health system itself, with a special focus in access and overall coordination of care. And the plan includes the commitment to have a final budget allocated to prioritized actions. In line with it, the Ministry of Health has transferred for the past year and for this year a total amount of more than 1,000 million euros to the region, highlighting 3 key projects. The first one is a primary healthcare infrastructure improvement plan. We call it MINAP. And the aim is for centers and clinical equipment to upgrade diagnosis and therapeutic resolution capacity. It is funded with 579 million. A dental care plan to expand but also to harmonize dental care coverage in PHC in all regions, funded with 112 million euros. And last but not least, a primary healthcare ambitious digital transformation plan funded by the EU with a total amount of 230 million euros. But it's also key to tackle, as we have seen, healthcare workforce and their situation. And for it, the most important measure we are taking is to reduce temporary contract, but also raise wages and facilitating access to continuous training and research for healthcare workers. But also the Ministry of Health have financed with 50 million euros more than 700 places for students of medicines in public universities. Other measures involve incurring later requirements, increase the number of training places for family and community specialists, medicine specialists, and other incentives to attract and retain healthcare professionals in PSC, private healthcare. In conclusion, we are working on a global project to achieve more and better primary healthcare. Thank you so much.
Thank you, Sulema, for your words and for highlighting some of the key aspects of health system strengthening that are needed for primary health care. But above all, thank you for championing primary health care in the European Union. Colleagues, conflicts, epidemics, financial constraints, and other concerns frequently dominate the political agenda. Resources are always limited, as Natasha reminded us, and still we want to sustain a primary health care approach. With that in mind, dear Bruce, could you help us reflect on what we should prioritize as we strive to keep shifting from health for some to health for all over the next 5 years?
Thank you very much, Gabriele. And before I jump into the question, I just want to take a moment to appreciate, Minister, the warmth and the with which you have welcomed us here today, and the leadership Kazakhstan has shown on this issue, and what we heard at the beginning in your reflections and those of the President. So, ladies and gentlemen, on the question I've just been asked, this is so important for us to remember. Yes, we all agree on the importance of primary health care, but we're not operating in a vacuum. We're operating in a complex world of increasing conflict right now, of climate change, of fiscal constraints, which are, of course, a challenge that to our ability to move the primary health care agenda forward. At the same time, we are in a world of aging populations, of increased NCD burdens as well. So we have a challenging environment. We're not operating in a vacuum. And Gabriele, thanks for the question, because in that we have got to be very clear on our priorities. So as we think about moving PHC forward in that agenda, our first priority has got to be the political dimension. We've heard about it again and again, but we have got to rely even more on stronger arguments and stronger rationale for the political leadership. Now, political leaders, remember, they are actually humans, believe it or not, and they are looking for solutions. So when we go forward and we say, here is a solution to your universal health care challenge, your coverage challenge, your health security challenge, your well-being challenge, you get 3 for 1. When we say this is something that will provide a health, an economic, financial, and social dividend, political leaders are going to listen. So you have a huge return potentially, but we've got to really invest in that political dimension. The second thing we've got to prioritize has got to be the people who need care most. And we've got to be thinking about the most vulnerable, the most marginalized populations. We've got to be thinking about the migrant populations. We had some great testimony to that effect at the beginning of this presentation. But as we get into this complex, we are in a complex global environment. It will only become more complex, and as it does, the most vulnerable are going to get hit the hardest. We have to remember that, so that's got to be our priority, looking at those populations. We heard a little bit about that from Spain, and Kazakhstan has prioritized that. The third thing we've got to get right and prioritize is the package. We've got to make tough decisions. It's got to be high impact, and the right interventions have got to be prioritized. We're in a world of 17 million premature deaths due to NCDs. We're in a world of huge concern about mental health challenges. We've got to prioritize those things the way we have prioritized in the past communicable diseases. But we're also in a world in which the maternal mortality has not moved during the SDG period. So we've got to have packages that address this, prevention and promotion. So we've got to get that package right. Fourth priority, don't worry, the list doesn't go on forever, there's 6. Fourth priority, we have got to prioritize the people, not only who need this care, but the people who deliver the care. We've got to prioritize the workforce. These interventions are not going to deliver themselves, or they're not going to be received without the people, the workforce, health and care workforce. We've got to prioritize that. And then we have got to be looking at where are the key barriers. And in her presentation, Natasha showed the incredibly concerning situation with respect to out-of-pocket payments. So it's great that we prioritize the first four things I talk about. We get the intervention package right, we get a focus on the right people, etc. But if that financial barrier to accessing these services isn't addressed, the financial protections aren't in place, we are not going to be able to move primary health care. And Kazakhstan, yesterday we heard this incredible intervention at the beginning of our workshop where you explained, Madam Minister, that for 126 diseases, the necessary medicines are available without out-of-pocket payment. That's the kind of ambition that we need to have if we are going to address that second priority as well around the people who need this most. And finally, in any environment like this, which is so complex, where so many things, other demands are crowding out the focus on primary health care, we've got to look at how can we accelerate, how can we get greater efficiencies? And this gets us to that last priority I'd speak to, is around looking at, and again, we heard it in the interventions this morning from one of our keynote speakers, I think all of them, digitalization. We have got new tools that can help ensure faster access to information, better tracking and monitoring of whether we're making a difference, and greater efficiencies, effectiveness in the entire system. We've got to embrace and harness the digital tools, the opportunity of digital and AI as we go forward. So, ladies and gentlemen, thanks first of all, Gabriele, for the recognizing with your question, we are in a complex global environment. World leaders and local leaders preoccupied with other challenges, fiscal challenges, climate challenges, conflict challenges in so many areas. And in that environment, we have to be even more resolute, more clear, more articulate, and better prioritized. We've got to put that political dimension first, put the people who need the care we've left behind, second top priority, that's what we've got to address. Get that package right with the high impact interventions, make sure we're supporting the people who deliver the care, the workforce. We've got to close that gap on the workforce. And then, of course, we have got to ensure financial protection and use the accelerated available. So yes, it's a complex world going forward. Politicians are looking for solutions. PHC is a fabulous solution. We've got to sell it right, sell the priorities right, and we will have the leadership we need behind it. Thank you for the question. Thank you for the chance to share a few perspectives on the priorities.
Thank you, Bruce.
Yes, thank you very much, Bruce. That was really great. Because we started this day very much in a celebratory mood. We're taking stock of our achievements, but it's so important to have a reality check as well and see where we have the obstacles. Now I'd like to move again to country level, and let's now hear from Georgia. Georgia has embarked on a very ambitious reform of primary health care to improve coverage, to provide integrated services, and there is a very big focus on rural areas. And what I like very much about Georgia's primary healthcare strategy, that it truly recognizes there is no one-size-fits-all, and the strategy in an urban area with a lot of private providers is different and has to be different than in sparsely populated rural areas where there are no private providers. So I have the honor to introduce Dr. Tamar Gabunia, First Deputy Minister from Georgia. And I have a particular question for you. You now have to take this strategy forward, right? You have to implement it. What obstacles and opportunities you see on your way, and how are you gearing up for this implementation process?
Thank you very much, Madam Minister, Regional Director, Your Excellencies. It's my privilege to be a speaker at this panel. Just a brief disclosure, I'm very biased towards primary health care as a family medicine practitioner, and in my current position as a policymaker, I am trying to promote the vision for primary health care and to make a very strong message that there is no way that any country can achieve universal health coverage without having a strongly functional and well-functional primary health care in place. As a government, as a policymaker, of course, we do realize that it's our responsibility to make sure that every single kid is fully immunized. Our senior citizens can treat hypertension, diabetes, epilepsy, and other conditions by having access to high-quality drugs. that we have pregnant provided with antenatal care, and that we have people with a late-stage cancer treated with dignity at a home setting, surrounded by their families and friends. These services can be delivered by primary care providers, and services aimed at making people more healthy or preventive services can also be delivered at primary care level. I'm not posing the question whether or not the primary care can take and fulfill responsibilities for delivering proactive preventive screening services or for delivering acute care for people with physical or mental health conditions. We already have plenty of evidence that yes, primary health care can do that. But at a country level, still there are some challenges we've been experiencing throughout the reforming the system. I've been part of the reform since post-Semashko period, and there were different priorities and different obstacles in front of us. Initially, it was very important to invest in family medicine professionals and develop the cohort of primary care providers thinking differently and being able and equipped with adequate competencies to deliver a comprehensive care. And then it was very important to invest in infrastructure and develop enabling policy environment. And nowadays, when we have human resources in place, we have better infrastructure, we have all means like clinical practice guidelines, protocols, we have access to best possible education and resources, it's not still easy to move ahead with the reform. First of all, it's very important to realize that primary healthcare reform is not happening over time, and we need to make sure that people understand the value and they appreciate services delivered by primary care providers. So one of the key focus of our health reforms these days is to educate the public and to work with communities to make sure that they get back to village providers. And on our side as a ministry, we do work very hard with our partners, and thanks to World Health Organization for technical assistance and support provided to the countries in redesigning policies and introducing new innovative solutions to, again, make sure that people trust in capacities of rural providers and they come back to receive very necessary, essential treatment and services. For the future, again, it's important to make our policy environment more flexible and responsive to community needs, to partner with community resources, community-based organizations, which helped a lot us to achieve our tuberculosis response goals, which help us to achieve our viral hepatitis elimination goals, and also to make sure that primary care providers partner more extensively with other sectors like social care providers as well as specialists working at hospital level. So these days we are trying to work hand in hand with other sectors like Ministry of Environment, because environmental health protection is also something that can successfully be implemented by family medicine practitioners. Health very closely with veterinary sector to implement the One Health strategy, and primary care providers are again at the front line of this process. So this is a very complex process. This is a complex reform requiring resources, requiring commitment, and requiring very active engagement of citizens, because this is something for people. So people need to really value and understand that without partnering with primary care providers, it would be very difficult for themselves to protect their own families, to protect their health. So this is something that we need to share broadly, and I think this would help us to overcome all challenges and obstacles we are experiencing on the way of PHC reform. I'm optimistic about the future prospects of PHC development, and I hope that this is really a path leading us to UHC and SDG achievement. So I thank you for your attention.
Yes, thank you very much for that. We are optimistic with you, and we are standing with you to be on this journey and to document it. You have heard from 3 very interesting countries from the WHO European region, from Kazakhstan, Spain, and Georgia. And I'm very proud to announce that this year we have published 3 country case studies from these countries documenting their journey on this path. So if you'd like to learn more about how they're implementing primary healthcare reforms, please do not hesitate to reach out on these links and access these interesting documents.
Thank you, Melitta. It has been already acknowledged this morning that the primary healthcare approach is a task that cannot be shouldered by the health sector alone, and that requires action in many other sectors. UNICEF, in the pursuit of its mission to fulfill children's rights, engages constantly with multiple sectors. So, dear Octavian, this goes to you. What key steps can we take in the coming years to truly embrace this multi-sectoral approach and transition from health for all to all for health?
Thank you, Gabriele, for the question. Allow me also to take a moment before answering it to express our sincere appreciation to Kazakhstan for hosting us at this very high-level conference, but also upholding since 1978 the principles of the Almaty Declaration. UNICEF, together with WHO, we have been privileged to accompany this process over the last over 4 decades. And I would like to thank our colleagues also from WHO for working very closely together, not only on the implementation of the principles, but also organizing this meeting. Indeed, Gabriele, the question you're raising about how much we can add to the existing capacity of the primary health care and what is the right balance between adding tasks to primary health care rather than bringing other sectors into delivering primary health care is actually not necessarily new. Multi-sectoriality and the whole government approach is one of the core principles of the Almaty Declaration. We know that it worked, and we heard this morning already the good progress made on improving maternal and child health, improving nutrition, improving immunization coverage that could have not been achieved without full engagement not only of the health system, but also education system, local authorities, civil society, media. So what actually changed over years since we had these principles since 1978? There are some things that changed dramatically. One is the way how we communicate, the way how we provide service, particularly linked to digital transformation, to new technology. Also what changed is the new burden of disease, new priorities for public health. But there is something that has not changed, unfortunately. We still leave many people behind. So referring to Natasha's principles for moving forward, I think we need to find some very practical solutions to translate these principles into concrete actions. And I would like to maybe reflect on this triangulation on bringing the service from the waiting room to the homes, communities, at the same time moving from monoprofile to multidimensional and using digital technologies. The good news is that indeed there are some very good models, and one of them we heard already this morning is indeed the model of Kazakhstan, which adds psychologists but also links health system with social protection and social work through, for instance, looking at how to build on assets using the community nurse system, building on the previous system of the Semashko model of the well-known patronage nurses, modernizing these systems, building it on evidence, but also allowing to address new public health priorities. Nurses under the universal progressive model provide an universal package for all families, but also are able to better detect early developmental delays or disabilities or cases of violence and work together with other systems to address these priority issues. So this model is implemented in Kazakhstan. We know that about 12 to 15 countries in the region are doing exactly the same, and I think it's a very practical way to bring these services as close as possible right into the homes of people. Second, we already addressed in a number of interventions this morning the growing importance of mental health and psychosocial support, particularly to children and adolescents, that became very evident during COVID. But while taking this service into the homes, adolescents, children, young people, they are somewhere else. They are quite often in the digital spaces. And how do we use technology to actually match this, quite often the gap between the beneficiary of the service and the service provider is another challenge. I was very encouraged 2 weeks ago to see in a meeting hosted by UNICEF in collaboration with colleagues from WHO, some global leading experts on mental health, but also representatives of tech industry. I won't name the specific industries, but I'm sure all know all of them quite well. And I think that is an area where we could really advance by building digital platforms for provision of services where our beneficiaries are. The challenge of multisectorality is always to move beyond sectoral budgets. And quite often that's what we discussed last time. I remember we came up in our one of the virtual roundtables with the idea of having perhaps cross-sectoral basic benefit packages. There are no ideal solutions, but I think when we look at the regional landscape, it's quite interesting and impressive to see how the European Union looks at addressing vulnerability and gaps in various service provisions across the life cycle of the child through the European Child Guarantee, which helps plan and look at gaps in service provision, be it health, education, social protection, and then invest additional resources through European social funds to address these gaps. My final point is the issue of trust. And that is certainly an area of multi-sectoral work which was particularly revealed during COVID. The role of health workers, particularly primary healthcare providers, on addressing misinformation, disinformation, which we know was the cornerstone of either being successful or maybe not that successful in responding to COVID. But in moving forward, we really see that the skill sets, the know-how, the capacities to work both in providing the service either in the health center, in-home, but also being digitally savvy and being able to exercise the authority. And we know the health workers have a tremendous role in conveying the health promotive and messages and doing health communication, but that quite often needs to be backed up also by other sectors. So allow me to stop here, and I would like to really emphasize that the challenge is there, but the solutions are also there, and I'm sure we'll be unpacking it during the day on the various meetings and sessions. Thank you very much.
Thank you, Octavian, for giving some very practical examples of how the work across sectors can benefit and provide additional platforms for primary health care and for putting the work we do in communities at the center of primary health care. Now, allow me to bring another strong country example, this time from outside the region. Thailand is a very well-known primary health care success story. This success has been grounded in decades-long emphasis and investment in primary health care, with significant investment in district infrastructure and community workforce. After Astana, even more effort have been put in place, including estimating primary health care expenditure. Now, dear Sura, has this more recent exercise led to increased primary health care spending, and how has this been affected by the COVID pandemic?
Thank you, Gabriele. This is a good problem that we, Thailand, can share to our colleagues. As you know, we invest in the infrastructure for more than 40 years ago. We have 10,000 of health centers, and we have 1,000 of community hospital last 40 years. We took the time about third decades. And in the same time, we produce the nurse and the paramedic along the infrastructure. So by now, we have about 800 community hospital and 10,000 of the health center. By the way, after Astana, Thailand have the Primary Care Act in 2019. The goal of the act is we propose to have the family care team that under the leading of the family doctor is around 6,500 team all around Thailand that cover the 70 million population. This is the step up the primary care under the family doctor. If you know, as you know that the expenditure or the spending in primary healthcare in Thailand, I think it's not much more. The number of the expenditure per capita is about $60 in 2002, and in 2020 it's about $160 per capita. It is depend on the aging and NCD is time to time. So it's not the expenditure. I think is an investment. If we investment in primary care, the secondary care and tertiary care will decrease the cost. So about the COVID-19, is it effect or not? The COVID-19, our government, we have the additional budget to cover all healthcare costs in COVID-19, including medical supply and vaccination and quarantine center. The primary healthcare was affected by the COVID in terms of disruption in other health service provision and supply chain disruption, limited access to primary healthcare, especially in urban setting, and referral from primary healthcare to secondary and tertiary care. And however, the pandemic raised more awareness on the importance of PSC. We will not be ready for the next pandemic if we have sufficient investment on strengthening PSC. As you know, in Thailand, we have only 10,000 primary care. We try to up to the primary care team that under the family doctor, as I told you. But actually, we have 1 million of health volunteers. In the situation of COVID-19, 1 million of health volunteers in the village level. They help Thailand to recover from COVID-19 pandemic, because only the 40,000 of health workers in the primary care is not enough to fight with the COVID-19. So health volunteer was trained to fight with the COVID-19, maybe in the state quarantine, or to advise the people to have the vaccination, or sometime in the hospital. So many things in Thailand that health volunteer is help Thailand to succeed in recover from the COVID-19. So the expenditure is not enough. Thank you.
Thank you.
Thank you. Thank you very much for sharing these valuable lessons. And for the final intervention from the panel, I would like to come to Bernd Appel from the European Commission. You are working very closely with WHO and with others as one of the partners to support countries on the path to universal health coverage. Partners will continue to play a very important role in our environment for the coming years. What do you think development partners can and should do in the next 5 years to assist countries in moving closer to realizing the vision of Astana?
Thank you very much. Before I start answering the question, I would like to thank our host to be so hospitable as they are today, and I think as they always are. I want to thank the organizers for showing us for who we are actually working and with whom we are working, to showing us a patient and his, in Kazakhstan, incredible good way for treatment in primary healthcare, which is not always the case in many other countries, but also in particular to give health work for the human face, to see under which circumstances they're working and traveling, which gives ourselves sort of the target goal. As development partners, we are probably furthest away from this interaction between a patient and between the healthcare workers. So what we can do is, first we need a strategy. Yeah? Fortunately, the European Union has a strategy and launched last year. Fortunately, also some of the European member states launched their strategies, global health strategies. The last one, France, last week, but one in the presence of your Director General. These strategies of European Union member states and the European Commission are basically combining 3 points. They look at the determinants of health, social, economic, commercial determinants of health, issues which determine whether we are healthy and whether we are ill, or whether we are ill, which are outside the healthcare sector's realms, where we can only respond. The other 2 goals look at health system strengthening in order to achieve universal health coverage and health security as 2 interdependent goals and being on the same coin, 2 sides of the same coin actually. So having a strategy, knowing where you want to go, the challenge is how do you do this? And I think for partners, I can only call to do this together. Yeah, development partners work in cooperation and not in competition with each other, as they sometimes do in the space of the global health, but also at country level. Europe has sort of decided to build this Team Europe approach, yeah, and to walk the talk and to do things together, which is very complicated looking at European Union member states and their ambitions and their targets and also as the diversities. But COVID has taught us in Europe that we are stronger if we do things together, if we agree after some kind of discussion where we want to go and how do we want to do this one. So that, as far as I'm concerned, is number 1. Doing things together, understanding each other's differences, sort of respecting each other's strengths and weaknesses, and trying to unite on a common goal. Second thing, also embedded in the European Union Global Health Strategy, is to acknowledge the role of WHO as the central pillar of global health. And recognizing that WHO is the only UN agency which has its own assembly. It gets its mandate from the World Health Assembly. 194 ministers of health sitting there next to each other, from very rich and powerful countries next to very poor and disadvantaged countries, facing the same problem, making sure their citizens, small or large in population, get access to services, access to essential health services. And taking cognizance of the fact that the entry point into a healthcare system is the primary healthcare level. I was fortunate enough to do, after my medical training, one of my first clinical experience in Zimbabwe in 1987-88, 10 years after the Alma Ata Declaration. And this is, as far as I'm concerned, a showcase what primary healthcare can do. Robert Mugabe, then Prime Minister of Zimbabwe, took the Alma Ata Declaration when he took power in 1981 and actually translated it into action, probably one of the first countries. And within 10 years, you saw indicators going up and indicators going down, the right ones in the right direction, and showing what it means to change a healthcare system which was pre-independence, serving 200,000 white settlers in a community of 8 million sort of indigenous black people who did not have access to health service and were really suffering, where everybody got access to primary healthcare service and indicators rising. So this is my model, how I still today, and if I see these country examples, is basically repeating this lesson over and over. Somewhere along the line, we have forgotten this, unfortunately. We had the MDGs, we had the SDGs, we had also the rise of the global health initiatives, which were created to address emergencies, which were created to eradicate diseases. But disease eradication and emergencies have an end in itself. If we continue adding on specialized agencies to treat and prevent special diseases, it's the contrary of what we like to do for health service strengthening and primary health care. So when the emergency is over or when the disease is eradicated, we have to take effort to integrate these global initiatives into the overall structure at the global, regional, but in particular at the country level, that a Minister of Health is not facing the WHO who comes and talks about health system strengthening and facing somebody who comes, but my interest is only this particular disease, and I give you 2 times more than you can get from the WHO or from your own coffers. So I think there must be an effort to bring this together, and the Future of Global Health Initiatives, which has started earlier this year, takes this as a mandate, how to transition this one into something which underpins health system strengthening. COVID has taught us that whatever we do in terms of finding vaccines, finding diagnostic, finding medicines, and I was never in doubt at any time that we would have a vaccine, but I'm always sure that certain countries' health systems cannot deliver this vaccine unto the last mile, into the last rural village. People then were surprised earlier last year, oh, we need to actually support countries and roll out. Yes, we knew this one from the very, very first beginning, because we know that some countries have got weak health systems. So what we are trying to do is to strengthen the role of WHO, being side by side with the Ministry of Health in all countries, and carrying this flag, health system strengthening, primary health care to achieve universal health coverage, and do as donors and development partners in a coordinated fashion as much as possible to strengthen at country level these activities to have national health systems which are able to cater for the needs of their people, be responsive and resilient of whatever healthcare threat which comes. Thank you.
Thank you very much, Bernd. Thank you for these thought-provoking remarks from the panel. Please join me thanking our panelists once again. We have come to the end of our first plenary, and you have had all a fantastic stamina. Gabriele, in closing, what is the one takeaway message you have?
Thank you, Melitta. I think we've all seen that since the Astana Declaration 5 years ago, progress is positive, albeit uneven. There are no mysteries to it. There are technical and strategic solutions. We heard of some of them. In the heart of today, we'll do some more reflecting on that. But at the end of the day, we see results when there is strong political will and sustained investment, especially in human resources for primary health care. That is what sticks with me, and I look forward to prosecute or go ahead with the reflection during the day and land on a renewed commitment for all of us to keep advocating for strong political will and sustained investment for primary health care. Thank you so much.
Yes, thank you very much, Gabriele. My takeaway point, I'm building on your point, is that there are successes. Let's learn what are the key factors of success behind these successes, and let's share that experience. But I'd also like to call for being better at documenting the contribution of primary healthcare to health, well-being, and social transformation. We're still not doing a very good job at it.